I've done most of my practice, probably the last 15 years or so, either in kind of neurosurgery, neurology, now in orthopedic spine, so I've kind of been always kind of in the neurology background. A lot of years I spent at the VA Medical Center, so that's where I got a lot of my neurology background and stuff, so most of this lecture and stuff is going to kind of come out of my basis out of being at the VA. Some of these slides that'll be in here will kind of pass through very quickly because Dr. McNeil informed me that you all get a neuroanatomy lecture right after this. Have fun. Just know that we had an entire neuroanatomy class when we had our thing. So be lucky that you don't have the entire class that we had. So it was, needless to say, a very fun class. And I have a master's degree in neurology and neuroanatomy. So, and I love neuroanatomy. I mean, that's my baby. I love it, and he kicked our ever-loving parts. So have fun. So today we'll talk about basically, I think, 4 different movement disorders that most of the time you'll kind of see during your practices, either in general practice, you know, pretty much anything you do, you'll pick up most of these along the way, and we'll just kind of go through the majority of them. I did not put on my work email. This is my personal email address. My work email address, you have to go through all these HIPAA regulation things, so it's kind of a pain in the neck to go through. So I put on my personal email address, so if anybody needs to get a hold of me, feel free to get a hold of me at any time. Right now I do orthopedics. I work for a company called OSOI. That we're here in the city. We work out of St. Anthony's and Bone and Joint, so there's a group of 10 of us, 10 surgeons, and I don't know, go anywhere between 9 and 11 PAs that work with the company, do all ranges of orthopedic surgery. So if anybody's interested in orthopedic surgery or interested in doing anything orthopedics and wants to tag along or wants to see anything on what's going on, give us a holler. We're more than welcome to have anybody come shadow in and take a look at us and see what's going on. First neurologic disorder we're going to talk about is Tourette's. Tourette's is primarily a kid's disorder, so you'll see a lot of this stuff if you do any kind of general practice. If you're doing urgent care, you'll see it. Sometimes it's kids come in. If you're doing pediatrics, you'll see a lot of this come through. It's very, very, very prominent in your pediatric population. Really, really, really old disorder. First described in a book actually in the 1400s, was described from this original publication, was notified as a priest who actually had a series of tics that they found. And usually you don't find this in adults. Usually you don't find this in adults, and they had this priest that would come over there and he would have all of these strange motor and vocal tics and stuff, and so they wrote an entire book about him in the 1400s with regards to it. Came along a little bit later. This gentleman here, which was a French physician, wrote about a woman who was very high in the French nobility, who had a condition where she would say some very strange things in the public and would kind of blurt things out and used inappropriate language, which was not very good in the 1800s for a very noble French woman to say some very explicit things in public to where she was not supposed to say. And so he had described this in several journals and had discussed this with regards to it. Later came on to the fact that she had also had Tourette's. In 1885, Tourette was actually one of the first neurologists that started working with this and actually started working with Charcot. Described this as a psychologic disorder. basically saying the fact that that it was a disorder that was purely psychologic in nature. You know, that there was no neurologic basis behind it, and that it was, purely, purely psychotic. That these patients were purely psychotic. It wasn't until the 1970s when they started coming out with a lot of neuroleptic drugs that they started treating some of these patients with some of the neuroleptic drugs that came out, that they finally discovered the fact that there might be some brain origin associated with the drugs, and they started figuring out that maybe there's some connection with, an actual origin, something growing on inside the brain, or something neurologic actually going on inside of the brain that would characterize this. Today we also figure out now that there's actually probably a component to both sides to it, because we do know that not only is there a neurologic origin to the disease, but as you'll see as we go through the slides, that there's also a large component of a psychological component to the disease as well. So we both go back and forth with both of it. This is the big slide that we're going to skip, because usually I go through a huge part of this with regards to the areas of the brain that's going to go through, but Dr. McNeil's going to go through this quite a bit. But when we look through it, it's actually related to both cortex going on starting in the cortex with regards to excitatory influence into the striatum. Then what we feel like the majority of that is it's the release or the disinhibition into the globus pallidus and the thalamus here that then actually creates problems that go on that creates the tics. So actually, you've got an excitatory process, and then you've got a part of the brain that actually comes in with neurotransmitters that you'll go in through later that actually inhibit that excitatory process. It's actually the disinhibition of that inhibition that creates the tic. So instead of actually exciting, it's not really the exciting part of it that's going on. It's actually the removing of the removing of the inhibition that keeps that tic going. Okay, so that's the area of research that they're working on to try to figure out what's the cause of it. And you guys will get into more and more as to what those neurotransmitters are and how that continues to work. I'm sure he'll go through that intensively. When you look at criteria as to what's going on, these are the criteria that it has to be able to fit, to be able to go. So we've got to look at the fact that there's multiple motor and vocal tics. Okay, so it's not just the fact that they have, a single little tic or something that's going on. These people have multiples, different ones. So they have, it's not just that they have one specific thing that's going on. They have multiple things, and we'll talk about all the different ones that they could possibly have. It has to be going on for more than a year. So it's not something that's just come on for a short burst of time and it's done. It's gone on for a week or two. Mom's come in and said, oh, they've been doing this for, they've been blinking for the last week. Something's wrong. Okay? No, nothing's wrong. They're fine. But it has to be going on for a while. It has to start before their age of 18. Most of these kids, by the time they're age of 18, it's gone. So that's a good thing to remind parents from a standpoint of what's going on, is that most of these kids will grow out of this. It's going to be okay. But it's a childhood illness, so these kids will grow, will grow out of this. And you're going to see this when they come in. Here's a big one. It's not a medication side effect. Okay. A lot of these kids come in nowadays and they're playing all these sports and they're doing all these things, and mom thinks that every single one of their kids that come in nowadays are asthmatics. They have a little bit of, tiny little wheeze that comes through, and oh, they have to carry their inhaler with them everywhere they go that's in their pocket. They have to take it with them everywhere they go. And the minute they had that little bit of, oh, I'm feeling a little short of breath, mom's screaming at them, have you used your inhaler? Have you used your inhaler? And they're playing soccer at, 9 o'clock in the morning, and they've got basketball practice at 11 o'clock in the morning, and they've got this at 1 o'clock in the afternoon, and they've got this at 3 o'clock. And oh, he has sports-induced asthma, and every time he plays, he has to take his asthma inhaler. So he's used his asthma inhaler. By the time he gets home, he's used it 17 times during the day. So he's puffed on albuterol all day long, and she wonders why he comes home and he's he's twitching all day long. Well, he's twitching all day long because he's been sucking on albuterol all day long. So you've got to look at the fact of what medications have we got him on, what are they doing, and is that what's causing what's going on? So be careful what's happening. Also, make sure that there's no other medication. Make sure that there's no other medical condition that's going on. Are we having seizures? I mean, do we have something else medically that's going on that we're missing that's happening? Is there a family history of Huntington's disease? We'll talk about it for a while. Are they just looking for behavior problems? I mean, are we just looking for attention? Are we looking for something that's going on? So, watch for all these things. Remember when we're dealing with kids that we have to kind of, look into the picture a little bit more as to what's going on at home, what's going on at school, what's going on with family, what's going on with us. Like I said, it's the most common movement disorder in kids, childhood onset, median age is at 6. This is hard. You'll read this everywhere. It'll say 1 out of 320. Other places will say 1 out of 100. Who knows what the incidence is, because, that's most probably go undiagnosed. They don't even take it to the doctor for it. They grow out of it. They don't have it diagnosed. It is more common in males. Like I said, more than half of them, they're gone by the age of 18. So you don't even have to, you don't have to do anything to it other than just encourage them that it's going to get better as they get older. When you look at these, basically what we're looking at is these are abrupt, brief, and repetitives. So they happen quickly. The biggest thing that you can talk to about a kid with them is this sensation or this urge that they have before they have it. They will tell you that they know that something is going to happen before it happens. They have this urge that they want to do the movement that they're going to do. They know it's coming on. They know it's going to be there. They know they have to do it. If they try to fight the urge, if they try to suppress it, it actually makes it worse. It actually makes them want to do it more. It makes them more frustrated by trying to suppress it. When they actually get that urge to do it, if they do the movement or make the sound that they're getting the urge for, then it goes away. So from that standpoint, that kind of helps them. And sometimes they can use that to their advantage, that we'll talk about later, that they can use that urge to their advantage to do little tricks to the trade to kind of make that kind of, go ahead and do the tic without making it so that it's not so obvious to the general public or disruptive to the general public, and move on with it so that they're okay. It is exacerbated by stress, excitement, suggestion, and suppression. So they're just like we talked about before. If you keep talking to them about it, if you keep, if mom sits there and keeps pressuring him about it and constantly putting it into their head about, why do you do that all the time, and stop that, and don't do that, or, whatever, it makes it worse. If you just ignore it and leave it alone, it's okay. So, but the more you bring it to attention, the more frequent it gets, the more frustrated they get, and the worse it gets. It does get better with physical activity. It does get better with distraction. So if we can do something to them, if we can teach them something, which again we'll learn in just a minute as to how we can do this, if we can teach them something that distracts them away from that urge, then sometimes we can improve it and get them better. This is one good thing too from a standpoint that does distinguish this from other things. The tics persist when they're sleeping. So unlike a lot of movement disorders, unlike a lot of tremors and things like that, that when people go to sleep, the tremors and stuff go to sleep, tics will persist while they're asleep. So you can see them when they're sleeping. Yeah.
Does it wake them up?
No, not usually. When you look at motor tics can be focal or they can be complex. Remember we said we need to see multiples. So usually you're not seeing just one or the other. You're usually seeing things kind of change around. So they'll have either focal ones where their eye blinking is usually the most common one that you'll see, but they can do facial grimacing, they can have jaw movements, head bobbing, shoulder shruggings, they can hop, they can jump, they can snap their fingers. A lot of them will snap fingers, but they can have these type of movements. A lot of them, or the majority of them, are kind of shoulders and up. You'll see from there. There's very few that come below. A few will have kind of a tap of the foot, but the majority of them you'll see kind of in that kind of head and shoulders area. That you'll see those. Vocal tics. Again, sniffing is probably the biggest one that you'll see. You know, people, kind of, just that whole time that all of a sudden just sniff. Throat clearing, grunting, snorting, repeating, echolalia is probably the most common of all of the true vocal tics. Coprolalia, which is the use of inappropriate, that was the French nobility lady who would go out and say very inappropriate words when she's not supposed to, is actually probably the most common thing that you'll see, and it's the thing that they use on boards all the time. I mean, on board questions, this word will come up over and over and over again, just to make sure that you know what the word means. But the fact of actually seeing it, and it's the one that when they talk about Tourette's on television or when they show it to you on commercials, they show these patients, but you never see those patients in practice. I mean, it's extremely rare to find these patients, so that's not very common. But it's the one that they like to use, I guess, because it's the most shocking. So it's the one that they like to use on test questions. It's the one that they like to use for shock factor. This is what we were talking about earlier. So here's Tourette syndrome right here in the middle. 85% of Tourette's patients will have a comorbid psychological condition. 85%. So when you look at that, that's amazing on how strong of a connection a neurologic condition can have with a psychologic condition. The majority of them will have shocking, ADHD, okay, or OCD. More than 50% of them will have ADHD or OCD. So when you look at these type of conditions, the other ones that are coming more and more common are coming in more into, you're seeing more and more and more of bipolar, particularly on those that are lasting past the age of 18. So that 50% that don't have the tics go away after the age of 18, we're seeing more. And those are going more and more in predominant into the manic stages. So you're seeing more manics. And the weird part is I saw some data not too long ago. A lot of those patients are being treated early in their Tourette's because, and I don't know why they've been treated, but you see a lot of those patients are being treated with antidepressants in the Tourette's very early in age, and they're using a lot of SNRIs very, very early. And they're showing that at 18, 19, and 20, that they're getting a lot of manics. So, I mean, don't forget when you're dealing with bipolar, those patients that are being treated with SNRIs or any antidepressants prior to being stabilized with some sort of stabilization material, some sort of stabilization medication, you're going to throw them into a manic state before, if you're trying to treat depression without treating the mania, you're going to throw them actually into mania. So that's really tough. Also, it's also showing a really high incidence of increased risks of suicides. And when you look at the data still, even with some of the black box warnings and some of the other things on antidepressants, on the use of antidepressants in teenagers, it seems to be a little higher in these kids with Tourette's of using a lot of even the new antidepressants in some of these kids that are older, that you get into the preteen and the teens and the early adults of using antidepressants in these kids. So be careful using some of those in that frame. And the hard part about it is when you look at using some of these kids that are being diagnosed with obsessive compulsive disorder, one of the treatments for obsessive compulsive disorder is to use antidepressants to be able to control that. So you have to be careful, because then what happens is you sit there and you treat this and you throw it into bipolar. So you've got to keep a close eye on these kids, or actually have them, make sure you've referred them out, make sure they're being watched by a psychiatrist at some point, to make sure that you've got them under control. Treatments. Here's the hard part with treating these kids is you've got a kid who's anywhere between 6 and 18, where do you start to treat, and how do you start to treat? A lot more people are starting to treat more with, as we go through some of these, getting away from some of the drug treatments because of the side effect of the drug treatments, and sticking more with cognitive behavioral treatments and doing other things from there. But there are medications that we can use to treat them. We can treat them obviously with typical antipsychotics, atypical antipsychotics. But remember, every time that you utilize these, you've got the side effects of medications. When you start with typical antipsychotics, in children specifically, you've got to worry about sedation effects. So these kids are coming in, and you wonder why you can't keep them awake in class. Well, you can't keep them awake in class if you've got them on Haldol all day long. So be careful when you're treating these kids with this type of medication. Aura seems to have a little bit less. These medications down here don't seem to have as many side effects. When you look at a lot of some of the typical antipsychotics, they don't have as much sedative side effects. A lot of these are also used once a day. A lot of them are used at night. So they will help, they will kind of wear off some of the sedative side effects, but they do have increased risks of suicidal side effects, so be careful with those in your teenagers. So just watch that. These are some of the other ones that they're using, not as effective, particularly your anti-epileptic meds aren't that used that much. Antidepressants, we kind of talked about that a little bit. Used particularly when you're talking about treating with OCD, but again, be careful with teenagers and suicidal effects. Ritalin and Adderall, actually with stimulants, initially thought could be worse, treating, from a standpoint of treating the tic, but actually have been shown to actually be a little bit of a benefit. So your kids with ADHD and Tourette's have been shown to do a little bit better with these type of medications. So those have been shown to be doing okay. There also is a big study, and I have not seen it, that they started doing this study, I don't know, probably 3 or 4 years ago, and I haven't seen anything about it lately. But they were doing a study on THC for a while, and I anticipate now with the whole medical marijuana stuff just really ramping up around the country, that we'll see that kind of come back into light for a while, and the whole CBD oil seems to be the cure-all for everything at this point in time. So I expect this to kind of come back into light at some point or another, but we'll see where that goes. Focally, Botox has been used, and it's actually been pretty effective, particularly on vocal tics. It seems to go good. Head tics, people that have a lot of jerking from a head and neck standpoint, seem to do fairly well. In several studies, about 93% improved with that. 50% were actually tick-free from that. We did have to worry about the fact that we did have, some of them did have decrease because of the vocal cord kind of, not real true paralysis of the vocal cord, but we did have some that, that we did have some decrease in the ability to project your voice. So, so that did show a little bit here, which could be of some concern, in the kids' population from there that, quiets them down quite a bit. Also, don't forget this is temporary. So, Botox, you're looking, every 3 months or so that you're having to give this. And in a kid, and Botox is going to have side effects. So, but if it's really bad, and in the right hands, that has been effective. We had probably, I think, 5 or 6 patients in the clinic in the VA who were adults that still had really bad vocal tics at the VA, and one of the neurologists was actually worked with an ENT doc, and between the two of them, they did Botox to sternocleidomastoid and to recurrent laryngeal and into vocal cords, and they actually had really good success with all 5 of those patients, that they had good, and at least to the patient they felt like they had quite a bit of improvement, and the patient felt like they were socially more acceptable from there, and they were, all 5 of them were really pretty bad. So, and they didn't require any medicines. They weren't on, they weren't on any kind of antipsychotic medication. So they really did well with it. But those were adults. So. This has been a lot in kids, and this actually, they now have it set up so that in a fairly easy way, even primary care providers can get online, and you can train and get trained on how to be able to do this, so that you can then train your patients how to do this. And the good thing is there's actually an ICD-10 code for it, and you can actually bill for it. So most important is that if you get trained for it, and you can actually spend time training your patients how to do it, you can actually get paid for training your patients how to do it. The comprehensive behavioral intervention training for tics is basically what it is, and what it's shown from a huge clinical trial was that there was about half of the patients actually had improvement 6 months out, and these were kids that were literally on 0 medication. And what it is, to make a long story short, is they learn through a series of training sessions that when they get the urge, how to do some sort of behavior that negates the urge to make the need for the tic go away. And that may be as simple as snap your finger underneath the table and the urge goes away so that the tic goes away. And through a series of some training online, and I sat down one day and it took me, I didn't finish the whole training thing, but I sat down for about an hour and kind of looked through it and tried to figure out what was going on. And it looked pretty interesting. I'm out of neurology now, so I decided I'm not going to take the time to really, set up to do it because it's fine and it's not going to benefit me anywhere and I'm not going to, have to bill for it anywhere. But it actually, it looked very good. And for somebody who would be in pediatrics and would have the availability to be able to do that, I think it's a good idea. So, and it keeps these kids off of drugs. But the other thing is that requires the kid probably not to have ADHD, okay? Because you've got to have a pretty disciplined kid who's willing to know their body, know their abilities, be able to concentrate on what their behavior is, and to be able to focus in on what's going on and be able to control it themselves. Because if they don't want to control it themselves, then they're not going to be able to really focus in on this and do this. And like it says here, most effective on older kids without ADHD. They're looking on deep brain stimulators. Why? I don't know. Maybe some of these cases that are, refractory that go into adults that are debilitating, but they work on deep brain stimulators for just about anything at this point in time. I did deep brain stimulators for years, but and for essential tremor and for Parkinson's disease, it's great. For depression, it's working out awesome. But for tic, it hasn't been as good. Deep brain stimulator actually is a probe that's actually implanted deep into various regions of the brain that then provide electrical stimulation to that region of the brain that then stops. That electrical stimulation will provide the neurotransmitter that comes out that will then stop whatever tic or tremor or whatever that you're looking for from there. They've looked at lesions into the thalamus and into the internal capsule of the globus pallidus. Here, it's actually obviously a brain surgery that goes through. I've not seen very many successful trials for tic. Closest center for Tourette's to here. Baylor has one in Houston. There's one in Kansas City at the Children's. The Tourette's Association designation here. For there, this is actually pretty good. They've got a lot of local things around the city. So they do, a lot of things locally with regards to walks and fundraising and stuff. So there's lots of things. And I think that's probably more than anything is when you have patients and stuff, getting them involved in the community, just like anything else when you have a kid, anyone with a chronic illness, the more that they're involved in the community activities and realize that, I'm not the only one out there that has this, the easier it is a lot of times for them to be able to control that. Move on. Essential tremor. Anybody know who this is? Okay, last year nobody knew. Yay! Catherine Hepburn, probably one of the most known from a standpoint that if you ever listen to her on Golden Pond, would know that, from a tremor standpoint of what it sounds like to have essential tremor, from a vocal standpoint, she's perfect for listening to what it sounds like. Essential tremor, when we're dealing with that, is an involuntary, rhythmic, oscillating movement of the head, upper extremities, and of the voice. Very common. You will see it, I guarantee. Genetic typically follows an autosomal dominant pattern. Doesn't have to, but that's usually what you see. Somebody in the family has it. Usually if somebody has it in the family, then, that's typically where you'll see, somebody will come in and say, oh, yeah, my dad had it, or, my grandfather had it. It's usually what you'll see. All kinds of genetic studies going on about it now. Every time you see, nobody's been able to find the gene yet. So, it's still out there. 50% will have a family history. It's probably higher than that. Median age is about 45. Location, hands, head, voice. If they come in and say it's in their legs, it's not essential tremor. Okay? It will not happen there. It's there. Again, check their medications. Make sure it's not coming from a med, that it's, that you're not causing something from there. Usually starts unilaterally. So hardly ever starts on both hands and starts going. It usually starts with one. Usually starts out really slowly, and over years will progress. It doesn't all of a sudden start out that your patient comes in and yesterday I wasn't doing anything and today I'm like this. Okay? It starts out that over years, oh yeah, I had noticed that I started having a little bit of shake, and sometimes they never even noticed it. It's the wife that tells you that, oh, he's been doing that for 5 or 6 years, and he doesn't even tell you that they've been doing it. Worse with stress, worse when they get tired, worse after the 15th cup of coffee. Okay? Worse in posture. What does that mean? So if I got my hands out here like this, okay, if I'm sitting out here and it's this hand, the longer I keep this hand out here, the more it starts to go. Okay? The bigger it gets, and the bigger it gets, and the more fatigued it gets, the bigger it gets. Okay? The more I try to move this hand, the worse it gets. So if I try to go to do something, particularly if I try to do something fine, that I try to take that screwdriver and that screw is right there, and I try to hit it from a standpoint that, and the closer I try to get to it, the more frustrated I get, and the more it starts doing this all over the place, and I can't get to it. Okay, that's pretty typical of what you'll see, what an essential tremor will look like. Wrong one again. Most common tremor that you'll see. Biggest deal is that who knows how many people have it, because most people go, well, you know what, Daddy had it all of his life. He never went to the doctor for it. I'm not going to either. Why? He died with it, because the doctor said that they couldn't do anything about it, so they're not going to do anything for me either, so why do I go? So, I mean, they don't go. Again, we just talked about this, worse with stress, fatigue, anxiety, movement, all that bothers them. The bad part about it is it starts, when it gets bad enough, it leads to social isolation. That's the hard part. It's fine until they come in and now they can't dress themselves. They don't go out to dinner anymore. Why? Well, it's a little hard to eat peas or have soup if you can't hold a spoon. Okay? So that social isolation is what you've got to work for. They can't hold a job anymore. What if you're a mechanic and you're right-handed and your tremor's in your right hand? It's a little hard to work on a car if you can't hold onto your tools. So those type of things. And the bad part about that is there are things out there. There are devices out there. There are weighted objects out there. There are medications out there. There are things out there that we can do that we can help them stay where they need to be longer if they let us know. So from that standpoint, we've got to, we can help. But a lot of times they just either are too proud and we don't know about it until it's too late. So we've got to watch that. Here's the hard part, and it's the one that you'll always see on tests. It gets better with alcohol. It's a modest amount of alcohol, so don't get drunk. But a lot of times people will say, if you have it, and it's an embarrassing in a social situation, 30 minutes before you go out in a social situation, have a glass of wine, and then go to dinner. Because things might get better, so you can at least go out, and you might make it through dinner, or make it through a social situation long enough that things won't, you won't notice. In the earlier stages, once it gets later, that's a little hard to do. But it does get better with a little bit of alcohol. And sometimes that's an easy way to pinpoint it when you're talking to patients is so if you come home at night and you have beer, does it get a little better? And they look at it and they go, yeah. And you're like, okay. It goes away when they're asleep. When they lay down at night and go to sleep, it's not there. Again, easy way to find this. When you're watching them, you ask them, it's easy, ask them to hold a pen, particularly if they're right-handed. Ask them to grab a pen, start writing. The minute they start grabbing a pen and start writing, you'll find out that these people used to be the ones at home to write checks. They don't write checks anymore. Okay? Have them hold their hands out, have them hold their hands this way, from a standpoint, try to touch their fingers together. Can't do that. Boy, this hand will just go, one of their hands that has the tremor in it will go crazy. If it's vocal, E or ah, that'll get them started and get them going. Writing skills, fine motor tasks, any of those will get them going. These are some of the things that we can look at from there. Vocation changes, it's a big one. If they're at a job that requires them to do it, we've got to watch what their job is and figure out what we need them to do. Biofeedback seems to work, relaxation seems to help. Watch their stimulants, watch their caffeine intake. Like we said before, a little alcohol before they get into a situation may help. I wouldn't suggest them drink a little alcohol before they go to work, but it may help. There are things out there. Wrist weights. They now come in, you find them on Amazon. They now come in on, even women have them, that they're really pretty little bracelets. And the bracelets are weighted. And they just have enough, grams of weights in them that it's just strong enough that you can actually hold on to something, and that just that additional weight on there is enough that you can continue to do things like write and do things from there. And you would never know, looking at it, that it's an orthopedic device. It doesn't look like it. Eating utensils, it looks like it's a normal spoon, but the way that it's made, it has a little bit additional weight in one thing. So, what do? You throw it in your purse before you go out to dinner, and while everybody else is, mealing around and going around from a standpoint, you sneak it out of your purse, you throw it up onto the table, and so while everybody else orders their soup, you sneak your silverware out there, and you grab your spoon, and you have your soup just like everybody else. Nobody has to know that it's a weighted spoon. Just don't forget to throw it back in your purse before you leave. So, those type of things are available out there, and it keeps you from saying, oh, well, no, I'd love to go out to dinner, but we can't go tonight, or I'm not feeling well, or, it gets you out of that social isolation type thing. All else goes awry and none of that stuff works, well, let's switch to medicines. Okay. We can do that. There's really two big ones that we use quite a bit. Primidone, myceline is one of them. The biggest thing with either one of these is tolerance. Okay? With both of the medications we're going to talk about, tolerance occurs fairly quickly. Tremors like to decide that the medicine's not going to work and we need more. So the important part of that is start low and go slow, just like any other medication. One, because of the side effects of the medication. Two is because you're gonna have to keep increasing it. And if you start with the highest dose, you're screwed. I mean, you got no place to go. So start low, slowly get them to work their way up. On myceline, It does work really good for upper extremities, so it really works good in the hands, particularly. All of your patients, all of them, I don't think I've ever started one person yet who didn't call me within 48 hours of starting it that said, I think I have the flu. And I'm like, no, it's just the medicine. No, I swear you need to give me a flu test. I think I have the flu. No, it's just the medicine. I mean, they really will. They feel like crap. That's why get started at bedtime. Because at least if they're going to feel like crap, hopefully they'll sleep through it. But almost all of them will tell you that, I mean, they ache. Their body hurts. And it's the medicine. But you gotta titrate it. But some of them can, I mean, they need 10 times, a lot of times, that dose that you normally start them at bedtime, that they can need it by the time they get to that point. Don't give it to anybody because of the sedation effects. Don't give it to anybody that's obstructive sleep apnea that you don't have on CPAP, because they won't wake back up. Obviously, sleep depression, anybody who's pregnant or breastfeeding. This will get better as it's that flu-like stuff. It will get better as it goes through. Their body will get used to it. But I've never taken it, but I mean, patients say it's awful. I mean, to the point where I've had several who called and said, all tremor. And I'm like, it'll get better, it'll get better. And I'm, no, all tremor. Okay. The other one is propranolol. This is the one you probably heard about way more. The good thing about propranolol is that, you know, with myceline, you got to take it all the time. You know, it's like hypertensive medicine. You know, you don't just take blood pressure medicine when you want to. You have to take blood pressure medicine every day. Myceline, because of the tremor, you have to take every day. Propranolol, you can take either as needed or you can take it chronically. A lot of people take propranolol when they need it. You know, if they're going to go out to do something, they'll take it. You know, they don't. If they feel like they're at home and they're not doing anything, they don't care if they're shaking during the day. They'll be all right. But if they're going to go out and do something, they'll take a little bit of propranolol so that shaking will calm down. So they'll take it kind of, you know, 30 minutes an hour or so before they go anywhere to kind of get themselves to kind of calm down and quit. If they take it chronically, again, we're going to develop tolerance to this. So we'll start low and kind of titrate up. The data in the journals and stuff show that the sustained release medicines on the propranolol actually do okay. In clinical practice, I never found that to be true. I found that actually taking the more rapid release part of the propranolol and taking it more frequently actually did better, and they were able to stay at a lower dose, and they just took like a half a tablet and put it in their pocket and took it a little bit more frequently, and they did better than taking a larger extended release medicine. I also found that it messed with their blood pressure and their heart rate a little less. So because they were able to take a smaller dose a little less frequently, they had less cases of orthostatic hypotension, they had less cases of bradycardia, they had less cases of, you know, some of the other side effects that came with propranolol. So, I mean, you know, it's going to be up to you when you're in practice on how your patients feel with it and how things go with propranolol. You know, lots of side effects with propranolol. This was a biggie, and what I found in, we had at the VA, we had several Desert Storm guys that came back with essential tremor. We're not sure if it was associated with vaccinations, whether it was associated with chemicals, whether it was associated with the fires, what it was associated with, but they're back with tremor. And they're young. They're 30 years old. So you got to treat them. I mean, you know, they're too young to just walk around with tremor all the time. They were a little different because they actually came back. Usually tremor starts unilaterally, you know, all this kind of stuff. They got tremor bilateral, and it comes on a little bit more aggressive and a little bit stronger. So you've got to treat them right away. Most of them, because they're military, are physically fit. They're usually not hypertensive. They're usually, blood pressure is usually a little low. They're usually already a little on the bradycardic side because they're physically fit. So they're coming into you with, you know, pressures 110, 115, heart rate sitting around 65 maybe, you know, because they still run, they're still, you know, they still may be either active or they're at least in the guard, or, you know, they're doing something, they're not completely out yet. And they're wanting to be on propranolol. Okay, so bad things about it. One, they don't like to exercise when they get on propranolol, so that's bad. Because it drags them down because of this. Two, their heart rate now drops down close to 40 something, which doesn't help them feel very good. Two, constipation sets in fairly fast. Three, sexual dysfunction sets in fairly fast. So those patients using the lowest possible dose and using it fairly frequently was the best thing that we found with regards to using propranolol on them. So we would use literally baby doses of propranolol, and they would take it, you know, maybe every 2 or 3 hours, that they would kind of throw it in their pocket and break the pills in quarters, halves and quarters, and throw it in their pocket and take tiny doses just to kind of suppress the tremors and keep them down. So, you know, when you're dealing with these population of patients, you have to kind of play with things to get them to go along. There's no way that they would have been able to take a sustained release type medication. One, because you can't sustain release, you can't break them, you can't do anything with them, because if you do, you mess up the way that the medicine's released. So you have to kind of play with populations, but don't forget side effects. Be careful with these. It used to be the fact that you can't put an asthmatic on beta blockers. It's not that you can't. It's just watch them. You know, make sure that it doesn't affect their breathing. So if they're on a ton of albuterol, if they're on a ton of medications because of their breathing, then don't forget those medicines aren't going to work, but just be careful. Second line, you know, for the longest time, people were putting these patients on benzos. Benzos are my least favorite drug in the entire world, so I don't put anybody on a benzo. But obviously, if, you know, anxiety is the reason you have a tremor, then, you know, people are thinking, well, if I put them on a benzodiazepine to take their anxiety away, then their tremor will go away. Okay. But you're just going to addict them to a benzodiazepine. Topamax, anticonvulsants, they don't work. Again, Botox, for your upper extremity tremors, no. For your head tremors and for your vocal cord tremors, they do work. Actually, Katharine Hepburn had Botox done, and the majority of her tremor from her vocal cord stuff went away. And she, there was a report, I don't remember how long ago it was, but there was a report at some point when she was with a reporter, and they asked her on what had happened to her tremor, and she said that they had done a procedure that made her voice better. And they said, well, why don't you continue it? She said, because that's not my real voice. And so she wouldn't go back and have it done again, because that's her mark, was her distinctive voice. And so she elected to continue to have her distinctive voice. So, this is one that the use of, not as much a thalamotomy anymore, but more on the deep brain stimulator. This is the one that you see a lot of use of deep brain stimulation for. The deep brain stimulator, it does go into the ventromedial hypothalamus, into the thalamus. It works. And I used to have, and I don't have it anymore because I officially don't have access to Medtronic's anymore. I used to have access to Medtronic's websites. And so I could get on and actually pull up videos for you all. But I'm sure they have them on YouTube anymore. If you've never seen it before, Google deep brain stimulator on YouTube, on essential tremor, and watch one. It is flippin' amazing. It is probably one of the most I don't know, I want to say fun, but it's not really fun, but it's probably one of the most exciting surgeries I've ever been involved in, ever, because it is a joy to sit in a case in an awake procedure where the patient's totally awake and talking to you the entire time while you're doing brain surgery, of which we did every Friday, you know, for a thing, and that you're doing a complete awake brain surgery on a patient who literally is like this continuously, and you know, you put this stimulator in and you're talking to the patient the whole time. Are you feeling okay? Are you doing okay? You know, we're going to get ready to turn it on. You're going to feel a little weird. It's going to have a little tingly situation, but I'm going to sit here and talk to you the whole time. You know, if you feel any weirdness or anything, I'm going to have you continue to talk to me because I need to make sure that your vocal centers and everything else are still going. So I need you to continue to talk to me. We're going to continue to, you know, talk backwards. I'm going to continue to ask you questions. I'm going to show you pictures, but I'm going to continue to just need you to talk to me. I need you to hold your hand up for me as we continue to talk, but I'm going to start turning on the stimulator right now. And we continue to have this conversation, and they continue to talk to me. And all of a sudden, as they're looking at it, their hand just stops. I mean, literally stops. And they start bawling. I mean, literally, right in the operating room, just start bawling. And I'm like, no, 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 I need you to talk, quit crying. And they're like, but, you know, and you know, as long as their vocal centers are still up, as long as everything's still going on, we're okay. I was like, okay, now we're going to do the other side, hand up, you know, from there. And then I have to turn it back off because we've got to close and we've got to do all that kind of stuff. And they're like, no, 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 you got to turn it back on, you got to turn it back on. I'm like, no, because now I got to push you off to sleep because we've got to close. And they're like, well, no, you know. We're like, no, we got to put you off to sleep now so that we can close everything, you know, because we're going to put the batteries in and that's going to hurt. And they're like, no, 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 you can't put me to sleep, you can't put me to sleep. No, when you wake up, they'll be on and everything will be okay and the tremor won't be there. But I mean, it is amazing to literally watch them go from a horrible tremor to nothing. More fun is post-op. Again, as they continue to heal and things go, they'll come back and, you know, they'll have to start to have some tremor, come back a little bit because their brain will get a little refractor to it and you'll have to make some adjustments, but that's why they have a battery in there. That's why you can make adjustments, okay? And they come back every 6 weeks, and that's why we can bill for adjustments. They come back every 6 weeks, and we have to make some little tweaks to what's going on. And they'll come back, and they'll be crotchety old men that'll come in there, and they'll be like, look at this, I got a tremor. You know, and they're just like barely moving, you know? And you're like, mm-hmm. I thought you told me I'd never have a tremor again. 1, never said that, okay? 2, why are you being all grumpy? Well, my tremor's back. It's not back. We just got to make a few adjustments. It'll be okay. No, it's back. I tried to do something yesterday and I couldn't do it, blah, 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 blah. Okay. So they get crabbier and crabbier and crabbier, and you're just like, you know what? It's been a really bad day. So you take the adjuster, you put it on their battery, and you turn them off, and you walk outside of the room. You come back in 5 minutes later, and they're like jumping all over the place, and you're like, okay, now your tremor's back. Can we make some adjustments? And they look at you and they go, I'm sorry. And you make some adjustments. and you walk back out of the room, and you know, then you fix it, and you go, okay, now go home. But, I mean, it's really amazing to see how well essential tremor does. I mean, it's fun for Parkinson's disease, but it is amazing for essential tremor. Amazing. And they literally, I mean, when you watch the video, if you watch a video, you watch them, I mean, every single one of them will cry. And they do, in the operating room, bawl like a baby. Again, a website for essential tremor. Essential tremor is fun. Huntington's disease. Anybody else know who this is? He's from Oklahoma. There's a city named after him.
Do you know what you got there? What do you got? What do you got there?
There you go.
I just noticed.
This is Huntington's disease. Discovered in 1872 by George Huntington. 1983, found the genetic link onto the chromosome number 4. 1993, discovered basically what it was the CAG repeat, known as the Huntington gene. That same year came up with the genetic testing available for it. Okay, this you will find in Oklahoma. There's actually a big pocket of it in Oklahoma. So you will, there are populations of it running around here all over the place. Autosomal dominant. Somebody has it. You got to find it. You got to track it down. Keep track of the whole family. It's found on the long arm of the 4 chromosome. Gene encodes for a protein called Huntington. It's repeats of the glutamine CAG repeat. Okay. Normal, there are 27 repeats of this CAG on this gene. Basically what we'll find is if there's more than 40 repeats, we're looking that they will have Huntington's disease. Like we said here, normal's 27. If they have 37, we're looking at a 50% chance of the disease. If they have over 40, I guarantee you they got it. If they have over 60, we're looking at what's called a Westphal variant. They're going to have it as a childhood onset, pretty early. It is not good. They're going to die early. It's going to rapid results. McNeil will probably go over this one too. Huntington's disease, the protein responsible for cell loss and gliosis in the basal ganglion and in the thalamus. So you get severe atrophy of the brain. Severe atrophy of the brain. Again, what we're looking at is loss in the inhibitory pathways, mostly within the dopamine pathways of the brain. So lots of things come with regards to what we see in the triad of this disease. Incidence runs anywhere between 7 to 10 per 100,000 in the United States. Usually onsets running around the 4th decade, so usually running somewhere between 35 and 39. We're typically looking at death at about 15 to 20 years from onset of the disease. Westphal variant, like we talked about before, onsets less than 20. These are the ones that have more than 60 repeats of the CAG. More severe, more rapid, death usually in 10 to 15 years. So these people are dying by the age of 30 to 35. Triad. Okay? This is what they'll talk to you about when they look at testing on these things. So when we look at the characteristics of the disease that we look through here, behavioral, cognitive, and motor. The behavioral is the big one on here. And the big one is the fact is that these guys or girls, are super impulsive. Okay? They are irritable, they're impulsive, they're depressed. Almost all of them are divorced at some point. A lot of them are in prison. A lot of them will either attempt or commit suicide. They may be charged with homicide. So, you know, these people are people from a psychological standpoint that have to be watched early and and have put into a situation to where they can have a support system very quickly so that we can get them help. Cognitively, executive function goes along right with the behavioral. You know, when we start losing and shrinking that much brain tissue, executive function goes out the window. So their ability to plan things, pay attention, concentrate, goes through their dementia, progresses rapidly. So we have problems with that very quickly. Motor function, you will see fairly quickly. The big one that they're always going to talk about is chorea. That's that dance-like movement. So, you know, their tremors are very different. It's not really a tremor, it's a whole body movement. So they're very clumsy, they fall a lot, they can't hold on to things, they drop things, they're totally unorganized. You try to throw a ball at them, they can't catch it. You try to ask them to do simple things like, and we'll talk about when they're doing a physical exam, stick your tongue out. They can't. They'll stick it out for a second, and then it's right back in again. They can't do anything organized for any extended period of time. They can't run their shin. They can't run down their ankle down their, or yeah, their ankle down their shin. They can't. So any type of physical exam that you try to get them to do, rapid alternating movement, nah. You know, finger tapping, can't do it. I mean, they just, anything that requires them to maintain any level of concentration or any form of coordination for any extended period of time is not happening. They are all over the place. Their thought process is, I mean, you'll start asking them questions and they'll be all over. I mean, they're just free range. I mean, they go everywhere with their thoughts. But the biggest one that they'll talk to you about from a testing standpoint is going to be this. So again, when you look at an exam, just like we talked about from there, is, you know, their flexion and extension movements. When they're sitting there on the table and talking to you, they'll be jerky. I mean, you know, they'll be moving all over the place as they're sitting there talking to you, and they can't sit still. There's just nothing they can do to sit still. Alternating movements can't do, cannot stay on task, won't look at you, they won't watch you. They'll look at you, and then they'll look up, and they'll look around, and they'll look down, and they'll just jar all over the place. They cannot stay on task. They can't swallow. They'll tell you they choke on their food all the time. Even water. They can't. Again, it's that whole just their ability to just be able to have any kind of controlled movement. Everything is just sporadic, and that includes swallowing. Nothing goes controlled. It's just all over. It's all awkward and clumsy. You throw a ball at them, they literally will let the ball just hit them, and they'll just let it fall in front of them. I mean, they won't try to catch it. They'll just look at it. These are the patients that need referrals. I mean, the minute they get diagnosed, boom. Here's the hard part about this. If there are new diagnoses coming in your office, don't forget, it's autosomal dominant. So that means that they've passed the gene. And if they're 35 to 45 years old when they've come in, and they're stuck out in a population of Oklahoma someplace, they may be a grandpa. So that means they have kids, they may have grandkids already, of which 50% of both of those have already passed the gene. So now we're already looking at a population that's sitting out there that have already got this, and we're trying to figure out how to slow this population down. So getting this into the system quickly, and getting people in, and getting people tested, and getting things started. They also may be of a generation or of a social situation or of a religious situation, or of an area where they don't believe in being tested. They don't believe in stopping what has been planned for them or for their society or for what's going on. So, so it becomes a very, very, very touchy situation for you and for everyone involved. But getting them into the getting them into the correct people to talk to is extremely important, and you've got to get that started. So getting them into a genetic counseling and getting them into a center that deals with Huntington's issues is important. We do have a center here in the city, so I mean you can get them into here. They have one in Tulsa, so but then it's the hard part is do they have transportation? Can they get to the city? Are they going to come to the city? But getting them into a scenario where we can get them tested, we can get their family members together, we can get their family tested, we can get people tested to determine how many gene repeats do they have. Are we talking about they've got 60, 70, 100 gene repeats? How bad is the disease that we're looking at? Get them referred to a neurologist. These people are going to have complex disease, they're going to have complex illnesses. We've got to look at what we're going to treat them with. There are lots of drugs out there that we can treat them with, but every drug has a side effect, and those side effects are going to affect other things that are going on in the disease, and it really shouldn't be managed by a general practitioner. I mean, it really needs to be managed by specialists. Getting them to both psychology or psychiatry, again, between the cognitive defects of these patients and between the executive functioning of these patients, they're going to need help. Most importantly, getting them into social services. The disease is a death sentence. I mean, they will die within typically less than 20 years. So if they're 40 years old and you know that they're not going to survive past the age of 60, they're not going to be on Social Security yet. So they are eligible to get them on SSI. They are eligible to get that type of stuff. They need to get a power of attorney. They need to get their will going. They need to get all of their affairs started and going and stuff because they have other people that need to be taken care of once they're gone. So getting that stuff started and getting that stuff going for them is going to be of importance. They need to, they're going to probably lose their job if they had a job. So, getting them started ahead of time on Medicare. It may take them 2 years to get Medicare. So if they lose their job in 6 months, you better have gotten stuff started on Medicare soon because they're going to lose their insurance. And they've got all of these bills that are coming from all these specialties. And if you haven't gotten them started on getting this stuff going, then, they're going to be in trouble. So getting them into that circuit is going to be really important. They're going to like you for it. Treatment, no cure. We haven't found anything yet to cure it. Only symptomatic, it's complex, it's continuous monitoring and adjusting medications, which is why the use of all those specialists is important. Basically, if you're not a specialist and you're their primary caregiver, your job at that point of time is to be controlling all their other conditions, their high blood pressure, their diabetes, all their other stuff, and making sure that everything else is staying organized and that whatever the specialist is putting them on is not doing something else to screw up all their other stuff, because I can guarantee those specialists are not paying attention to what medicines that they're on for hypertension and for everything else, and make sure that they're not putting them on something that's screwing your medicines up. So your job is just to make sure that the specialist isn't messing you up if you're not one of the specialists. So so that's going to be your job. The specialist is going to take over everything else associated with the Huntington's disease. Behavioral wise, there's going to be multiple things here. Minimize your medicines as much as possible. The more medicines that you put them on for behavioral problems, what you find is the more problems that they have. because you're just going to give them more problems by the side effects of the medicines than you are by treating the problems that they have. So be careful with what you put them on. Cognitive, all of the medicines that we use for dementias, you know, for Alzheimer's or whatever, and Huntington's disease have shown to provide zero effect on Huntington's disease. The progression of the dementia is so fast that they really have not shown to really do much effect at all. So doing that is, you're just going to add side effects from the medicine, so it's really nothing from there. Tetrabenzene is really still the only FDA-approved drug from there. The hard part is black box warning on tetrabenzene, increased risk of depression and suicide. So you just put a patient that you've just given a death sentence to from, you know, Huntington's disease, and you just now put them on a medicine that puts them at increased risk of depression and suicide. Thanks. You know, so these patients need to be watched closely. Again, societies here, closest big centers. Here, there's one in Omaha. Houston has one. But there's some pretty good ones in Oklahoma, because there is a couple of big pockets of Huntington's disease in Oklahoma. Last but not least, let's hit some Parkinson's disease, and then I'll get y'all out of here. The biggest thing to deal with Parkinson's disease, and this seems to be kind of a hot topic right now, is the difference between, a lot of times people will give a diagnosis of Parkinson's disease when it's really more Parkinsonism and not Parkinson's disease. A lot of things can give you Parkinsonism. You know, it looks like Parkinson's-like symptoms, but it doesn't necessarily mean you have destruction of the substantia nigra with loss of dopamine and actual Parkinson's disease, okay? So make sure when you're talking to your, and your patients may not know the difference. You know, you say the term Parkinson's to a patient and they may think, oh my God, I have Parkinson's disease. I'm gonna look like Michael J. Fox, and you know they throw that immediately into there. There's a lot of things, medications, a lot of drugs, a lot of things that can give you those type of symptoms that you can take the medications off, you can do things from there, that you can change things. So just make sure that you are specific with your patients to let them know what they're, don't give them a diagnosis of a disease that they don't have. Okay, so be careful with that. So a lot of things can be similar to what's going on, and just make sure that they know what they have. Shy-Drager syndrome, which is a multi-symptom atrophy. This is all pretty rare from a Shy-Drager, but it looks like Parkinson's disease. But you're going to have an upper motor neuron syndrome, upper motor neuron signs. So you're not going to have that in Parkinson's disease. You're not going to have, you know, 3+ reflexes. You're not going to have all of those kind of things, because you have brain atrophy. Okay, so if you have a patient that comes in and looks like it has Parkinson's disease, but all of a sudden you test them and they have all these symptoms that looks like it has a brain dysfunction, okay? It looks like there's upper motor neuron stuff that's going on. Well, that's not Parkinson's disease. I better look in the brain or in the central nervous system and find out, is there something else that's going on, okay? So just because it looks like Parkinson's disease doesn't necessarily mean it is Parkinson's disease. You've got to look at other things too. You've got to make sure that there's not something else that's going on. Progressive supranuclear palsy also looks like Parkinson's disease, but when you look at their gaze, when you look at their eye function, it's really associated with eye function. These people can't look down. Okay, so they have no vertical gaze, so they can't look down. So, you know, it looks like that, but they have other things else that are going on too. So you have to be really careful with these. Lewy body dementia, it's a profound dementia. Parkinson's disease don't have dementia until really, really, really late in their Parkinson's disease. okay? So if somebody comes in and, they have something that kind of looks like Parkinson's, but it's, but their big thing is that they're extremely demented, well, if it's new onset, it probably isn't the Parkinson's disease, it's probably something else that's been going on. We gotta go look at the brain first and see what's happening. Normal pressure hydrocephalus, basically it's, too much pressure and, too much, well, the pressure is normal in there, but too much fluid within the brain. These patients will have a urinary incontinence. You look at them, they'll have these huge ventricles in the brain. But if you try to test the pressure on them, the pressure's normal. But they'll have slowness in gait. They'll have things that look kind of Parkinsonism, but they have all this brain, there's no brain in there, and they have all fluid in there. But they'll come in with the urinary incontinence. Essential tremor, they've got a tremor, okay? But it doesn't look like Parkinson's tremor. It's a totally different kind of tremor. So we'll look at that. Huntington's disease, again, have a tremor, different kind of tremor. Wilson's disease, encephalopathy, there's an infection in there at some point or another. Again, medications, particularly dealing with things like your metoclopramide and your phenergan. I have seen patients over and over again from a surgical standpoint, people who come in that have been put on phenergan or Reglan for post-operative nausea and vomiting. And you come in and the nurse calls you in the next morning and they're like, oh my God, they've had this, tremor all night long. And I'm like, were they on the morphine PCA? Yeah. Were they vomiting all night? Yeah. Did you have them on Reglan all night long? Yeah. When did they start the tremor? Somewhere in the middle of the night. Did you stop the Reglan? No. Stop it, please. And it's because of that. The bad part about it is if a bunch of these doesn't go away. Or if it does, it takes a very, very, very long time to go away. So be careful. If you have a patient that starts a tremor on Reglan or phenergan, tell them to stop it immediately. Because if they don't, that tremor will stay there. A lot of times too, it's a head tremor. They'll get that kind of head bobby type thing that's going on, and it's freaky looking, and it does not like to go away. So, and then it does kind of look like Parkinson's disease for a while. Like we said before, this is the loss of dopamine in the substantia nigra. So when you look at a brain section, so here's the substantia nigra. The dark cells are dopamine-containing neurons in the substantia nigra. So here's a Parkinson's disease brain. Loss of those dopamine-containing neurons. Incidence, progressive neurogenic disorder, usually 160 out of 100,000 prevalence, mean onset about 60. It's pretty slow progressive, so most of these patients, I think we're seeing a little bit more and more new onset. In fact, I was watching last night on, what's that, American Ninja Warrior. They had a guy on last night that was, that competed that had Parkinson's disease. It was actually pretty amazing. He actually did pretty good. And 3 of their events last night was a lot of hand grip strength, hand grip and kind of stability stuff. And I was like, oh, he is never going to make it. And he lost on one of them that literally was a hand grip. And I was like, there's no way he can make it through 3 consecutive hand grip things because their biggest thing is going to be on grip strength. And I was shocked. But I mean, he literally would stop in between. And I mean, this hand would, start that pin rolling tremor just, I mean, immediately the minute he would stop. And I was like, how in the world he can hang on? I couldn't believe it. He's raised over $250,000 alone for the Fox Foundation on his own, running marathons and doing stuff. More often in men than women. You'll see it. UK set up a criteria to fit it from a standpoint. Slowness. This is going to be the biggest one that you see. These people move slow. Everything they do is slow. They talk slow. They chew slow. They move slow. Their family will tell you faster than anything that everything they do is extremely slow. Then after that, they have to have at least one of these. So rigidity, which you'll usually find more in an exam, which we'll talk a little bit about, arresting tremor, or postural instability, and we'll talk a little bit about that too. Supportive criteria, based on the other, then we have to have at least 3 of these. Typically, starts on one side again, unilateral onset. Progressive signs and symptoms, this doesn't just bam hit, and then it goes like wildfire. It works slowly. Remember, we're talking about a loss of neurons in the brain. We don't just one day wake up and all the dopamine neurons are gone. They slowly just kind of fade away. Persistent asymmetry of the affected side, in other words, they just slow. Responsive to dopamine. It's a loss of dopamine in the brain. So if I give it dopamine, it's going to get better. So it's a good way from a standpoint sometimes of just finding out if it truly is what it is. I mean, if we think it's Parkinson's disease and I give them dopamine that crosses the blood-brain barrier, do they get benefit? If they do, then I probably got a diagnosis. If I give them enough dopamine, do I get side effects from the dopamine? Because too much dopamine actually makes them worse. It gives them a dyskinesia. Does anybody know who Michael J. Fox is? Oh, yay. Okay, so he hasn't gotten old enough yet that people don't know who he is. Has anybody watched him give a lecture? Okay. When he gives a lecture, you know how he's always so animated when he gives a lecture and everybody says, oh my God, that disease is so horrible? Okay? It's not the disease. He takes too much medicine before he goes out to give the lecture to make it look horrible. Okay? Because the medicine is what gives him the jerkiness and the dyskinesia. Okay? Remember we said the Parkinson's disease, you're slow. Well, if he goes out there all mopey and slow, he can't get through an exciting lecture. You're all going to think he's boring. Okay? But if I take a big dose of medicine and I come out here and I'm all hyper and all animated, then I'm exciting and people will listen to what I have to say. So he takes extra medicine before he goes out to give a lecture and gets him all kind of round up and going. So it's this that makes him responsive to what's going on. Okay. Clinical course for more than 10 years. Okay. It takes a while to get this disease and to progress this disease. That's why when people are told that they have Parkinson's disease, I think a lot of times people think, oh my God, I just got a death sentence. And I'm like, you're 60 years old. You've just been told you have Parkinson's disease. I mean, it's going to take a while. I'm afraid to tell you this, but something else is going to probably get you before this does. So we're going to do some things to try to make your quality of life a little bit better over these next 10 years so that you don't show the symptoms as fast and as long. And yeah, it's kind of sucky, but you'll be all right. Okay. Primary, obviously, is the loss of dopamine and substantial migraine. But we can also have things secondary that have caused things, and these are some of the things that you will see from on the board. Okay, so we can have drug-induced Parkinsonism from medications that we put patients on. So some of these dopamine-depleting medicines that we have people on for other conditions. So our patients with the thing Huntington's disease, thing we just talked about, meperidine, reserpine. So these antipsychotics, these type of medications can cause antiemetics, Zofran, those type of medicines that have been on for long periods of times. These type of medications can cause dopamine depletion in the brain. Okay, you've been on it for a long period of time, and now you've actually given yourself, or your doctor's given you, because you didn't prescribe it, your doctor prescribed it. Your doctor's now given you Parkinson's disease. Okay, this is how it was actually. One of the things that first kind of figured out what it was We were synthetically making drugs and synthetic cocaine in Los Angeles, in Poughkeepsie, and people started having Parkinson's-like disease in LA. Multi-infarct dementia, hypertensives that aren't well controlled, they get all these little, tiny little microvascular disease things that are going on. So diabetics who aren't controlled, who have high blood pressure, that we're starting to get a lot of these multi-infarct dementia type patients. A lot of these are hitting deeper and deeper and deeper into brain structures. So you get a multi-infarct into that substantia nigra, into those deep brain tissues. We're going to start seeing a lot more effect deep into this area where we have it. Also, one of the areas that we're seeing more and more now, that's getting more and more publications now, we got movies out based off of it. Muhammad Ali was on my picture to begin with, is the post-traumatic. So those people that are getting punched around or beat around from football players, we'll see. I think this is going to be a big one for a while now that it's, the NFL is now actually admitted to it, that we're going to see it as those population of football players are starting to get older now. We're going to see more and more of that starting to occur. So this I think you're going to start seeing more of that population because of that. These patients are tired. This is probably one of the first things that I have patients that we have a Parkinson's clinic at the VA. And this is, I think, probably one of the first complaints that I would see is insomnia. Those patients would come in and they don't sleep. I don't know why, but they don't. Foot cramps at night, that's maybe why they don't sleep. But they would see restless legs, depression, fatigue, again, probably all from a standpoint of no sleep, that all that comes in. Minor cognitive stuff. Most of these people were still taking care of the financial issues at home, still taking care of everything from there, but notice that it wasn't coming as easily to them, They weren't as quick to balance the checkbook. They were having more issues with it. They would have more mistakes. But they were still doing it. This is also another one. Food doesn't taste good. That was the biggest, between not sleeping and food not tasting good, were probably my two biggest complaints of people that would come in. And it wasn't the fact that food didn't taste good, it's the fact that they couldn't smell it. So loss of smell was very early into what's going on. This is what you'll see when you do an exam. Slow ocular movement. So you do eye testing, you literally, your finger's like here, and usually you'll do an eye test and you're kind of like this, okay? You'll start to do that, and you'll go back and you'll go, okay. Because that's how fast, they can't, if you try to go faster, they're just like, wow, they can't do it. So you have to slow down to do your eye test because they just can't do it. Meyerson's, remember, tapping right between the eyes. We all can, if you tap between here, you're not going to blink. You can force yourself not to blink. They can't. As you start tapping, they will instinctively blink. I mean, they can't not do it. Mass facies, what does that mean? As you're looking at them, they just don't have an expression. That face is just kind of there. I mean, are you smiling? Are you happy? Are you not? Will you smile for me? I mean, can I get anything out of you? I mean, there's just nothing there. Again, dealing with the whole, fine motor and being fast. Finger tapping, they can't do that. Supination, pronation, they can't do things fast. Finger to nose, again, they can't do things fast. Coordination, have them cross their hands and sit and stand. Okay, sit to stand. They're not, they can't do it. I mean, they can, but they're very slow in their ability to do it. A lot of these come much later. So watch them when they walk. Typically when we walk, okay, our arms swing. Okay? If you walk with someone who has Parkinson's disease, their arms stay perfectly still. As you walk, they have no arm swing. Their arms will just stay straight down to their side. As they turn, when we turn fluid. So we kind of turn and just come back the other way. They will block turn. So as they turn, they literally will stop and kind of, literally they have to turn themselves and kind of block turn their way around. Okay? Have them write. Every time they come in, have them write a sentence. As their disease progresses, their writing will get smaller. And what will end up happening is they will stop doing things like writing checks and doing things, because as they write things, their writing will get teeny tiny. And you'll notice it eventually is when they first write a sentence, their normal part of their sentence will be normal, and by the time they get to the end of the sentence, it'll be really tiny. And then after about, you've seen them, I guess I was following patients about 5 years or so, and you would see it, and then by the time after about 5 years, their whole sentence would be this way. And I literally would pull out files and show them. It's like, well, here's where you started, and here's where we're at now. The hypophonia, the biggest one is ask their kids how they do. Because where you'll find it is how they do on the telephone. Most of them won't talk to their kids on the telephone anymore because they can't hear them on the phone. Because as they're talking on the phone, their voice gets so quiet that their kids can't hear them. And they're always talking, Dad, speak up, I can't hear you. So they get really quiet on the phone. So usually you'll ask them, do you talk to the kids on the phone? Or if their kids are there with them, can you hear him on the phone? Can you hear him when he calls you? They're like, no. So those are type of things that we talk about. Tremor in here is that traditional pill rolling tremor. So you watch them, and I don't talk to them about their tremor, I don't do anything. I just, as we're talking and as we're conversing, I'm watching. And you will almost always notice, and a lot of times they don't even notice, as you're watching them, they just have that very subtle, just like they have a little pin in between their fingers, will just have that little roll. Almost hardly ever will it have that big craziness to it. Usually it's really subtle. Most of the time, if they move, it goes away. So the minute they go to do something, it's gone. Like I said, it's real low frequency. So unless you're ignoring it and not paying much attention to it and not making a big deal out of it, a lot of times you don't see it at all. And about a quarter of them don't even have it at all. So a lot of people, most people will just associate it with, well, if you don't have a tremor, you don't have Parkinson's disease. Not necessarily. When you're doing their exam, their head and neck range of motion is really decreased. So, as you kind of, if you can get them to relax, which is really hard to do, and if you grab their head and just kind of try to passively move things around, it feels really tight and stiff, okay? If you take their upper extremity and you move them around, it feels stiff. If you take their wrist and move it around, you can get what's called cogwheel rigidity, okay? You'll see that in tests a lot. What does that mean? What's a cogwheel do? It kind of ratchets, okay? The best way to do that on an exam is have them do something else with their other hand. So a lot of times I'll have them like tap their other hand or do something. I need them to distract them. I need them to do something else so they're not concentrating on me so that I can really move their other hand. Because if I'm trying to move this hand, they're trying to help me move it, okay? But if I'm trying to if they're doing something over here and I've got them distracted, then I can move this hand and I can really feel that rigidity. I can feel that cogwheel go through it. And it's actually kind of, it's definitely, you can feel it. It feels really kind of strange, okay? But distract them from doing that so that you can get that feeling. Pull test or retropulsion. If anybody ever knows what that is, it's kind of that cerebellar test. So you know when you do a cerebellar test, if you got somebody standing in front of you, okay, and you pull someone back towards you, okay. As you pull somebody back towards you, their instinct should be to correct that, okay, to kind of come forward to correct that instability, okay. In these patients, as you pull them back, be ready to catch them because they're going to land in your lap. Okay? As you pull them back, they don't have that stability. So when you pull them back, they're going to do this. Okay? I know what was on about that. So they're going to come back with you. Okay? So be prepared for the fact that they don't have that stability. So if you start doing an exam, be ready for that. Much later, everybody always talks. Everybody always talks about this shuffling gait. Okay, you don't see that very early. You see that late. But what you will see pretty early is a forward flexion. So you'll see a patient start as they get up, start to walk. Remember we talked about the fact that how hard it is for them to kind of get up and get going. When they do get up and get going, because they got to get that forward motion of, that dyskinesia gets them started. When they get that forward motion going, they start with short, choppy steps. So they kind of get that, kind of going. And so that forward propulsion to get them moving puts them into kind of that forward flexion of a gait to get their feet going. And then eventually they kind of stand back up, and then that's when that slow kind of gait starts. Now, that shuffling that they talk about is more of, I think, that kind of that getting them into that propulsion of going. That I gotta go. They'll have those periods of what they call on and off. So when you look at those, when you look at the patients as they take their medicines, you'll ask them about their on-off periods, and what that means is there'll be times where they'll actually almost want to freeze. They'll start going, and it's like, well, I want to go, but my body doesn't want to. And then they'll kind of go again, and that's pretty typical. Their medicine's helpful for that. Later stages, we start really worrying about dementia, but that doesn't occur until much later. But from the beginning, do a mini mental, because it's so slow to come on. You're not going to know what's happening until it's too late. But if you're doing a mini mental exam every time they come in, you're going to catch some of the things early enough that maybe you can start doing a few things ahead of time to start helping them with some of areas of cognitive decline earlier, so that you can continue to delay it if you catch it fast enough. If you don't wait until all of a sudden now their mini mental is so far gone that now you can't do anything about it, then it's too late. But if all of a sudden you're seeing a 2 or 3 point decline, and you're like, oh, well, look, we've got a little bit of decline here on X. Let's start working on, some, different games, or let's start working on some different things that we can help you do that, so that we can help make that better. Imaging. You usually don't need imaging. If they're a 60-year-old and they have symptoms of Parkinson's disease, imaging is not going to tell you anything. If they have some of those open motor neuron findings, if they have stuff that makes you wonder, is this really Parkinson's disease because they have something else that's going on? Well, then yeah, you've got to go look deeper to figure out what's going on. If they're young, then remember we said Parkinson's disease doesn't usually hit till they're 60. So if they're younger coming in, yeah, you better go get an MRI, because what if something else is going on that you need to treat? They do have what are called DAT scans, which are SPECT scans that actually look at dopamine. There's some centers around that do it. I don't know what the use of it behind it is, but you can look. It's a nuclear study. treatment early, you know, are going to be things, start getting them into things like physical therapy, speech therapies, you know, physical therapy, keep them strong, keep them active, keep them working on things to keep their strength up, to keep their core strength up so that, you know, their movement and their stability and their postural instabilities and all those stuff stays strong. Keep their speech therapy up. Keep them going on things. They have instruments now that you can attach to your phone that, you know, are microphone type things that, you know, will help keep your keep it so that you can stay in contact with your family members, so that you can, you know, do those type of things. So those things of social isolation and things that lead to depression and anxiety and all that kind of stuff go away. You know, so that you don't have those type of issues. So, you know, get them involved in those kind of things so that they don't start avoidance already, so that you don't have problems. Medications we'll talk about. Surgery obviously is also available. We'll talk about it too. Early stages, some of the treatments that we're looking at. Later stages, obviously, if you're looking at people over the age of 60, we'll talk about as well. These are some of the anticholinergics. The thing is remember we talked about the fact that the treatment, the cause of Parkinson's disease is dopamine, loss of dopamine. So what's the treatment? Dopamine. Okay. What's the problem? Okay. Problem is too much. Problem is also, from a standpoint, is that it doesn't last. Okay. Dopamine has a finite life with Parkinson's disease patients. We said it loud. Parkinson's disease can last a long time. Okay. Well, if I start dopamine too early and I run out of time that the patient's still going strong and the dopamine's no longer effective, I'm in trouble. So until my symptoms get bad enough, so there's still dopamine in the brain, okay? It's just kind of like pre-diabetes versus diabetes, okay? I used to hate the term that people used to come back and say there was pre-diabetes. You're either diabetic or you're not, as far as I'm concerned, okay? But when you're pre-diabetic, you still have insulin that's still there. You still got things that are going on. If you do things to protect that, in other words, you eat right, you exercise, you lose weight, you do things, hopefully you can make that last a little while. Well, we now think that if we do some of these things here, that we can help with some of the issues that are going on. Maybe we can make the dopamine last in the brain a little while longer. We can make the symptoms a little less bad, that we don't have to start dopamine for a little while longer, so that we can get these patients to live a little while without the use of dopamine, so that we don't let the dopamine run out. As patients live longer, our treatments have to last longer. So that again becomes the hard part. A long time ago, 30, 40, 50 years ago, patients didn't live. You know, our median age was what, in the mid-70s? You know, now my grandmother just died at 102. So, you know, now as our median age gets longer and longer, these medicines also have to last longer and longer. So we have to be careful with that. So some of these patients are being started at earlier stages with some medications that will hopefully treat some of the symptoms without starting them immediately on dopamine. Then we start medications like these from a standpoint on dopamine. Carbidopa, levodopa, Cinnamate, which is a medicine that we usually start with. Levodopa is able to cross the blood-brain barrier. Okay, that's important because not many medicines will cross the blood-brain barrier, and we've got to be able to get this into the brain so that we get it to effect. Okay? The bad part about it is it causes nausea. Right? What we know is that by adding the carbidopa to it, we improve the nausea. So adding both the medicines will affect that. Again, don't start until the initial symptoms become refractory and debilitating so that we can have instability issues. The bad part of the side effects is the dyskinesia. So again, the whole deal with Michael J. Fox's is the fact that you take too much, then you have it. The hard part about that is with the patients, is sometimes they really do want to take more because it makes them feel better. Okay, but you got to talk to them. Is more is not always good. So they have to find that happy medium between what's going on. And the more they use, the more likelihood they're going to burn themselves out sooner. So they've got to take the amount that's needed. If not, we're going to need to start going to some of these other agents. Some of the other agents, when the standpoint is using some of these other agents, these are also dopamine agents that are used to benefit or to add effects to the sentiment, so they can actually boost these effects. So when we start losing the effect of sentiment, when sentiment's no longer working, we can add some of these agents to it to get it to work a little longer. Okay? We can add COMT, is basically the enzyme that breaks down dopamine. So there are inhibitors to COMT that I can add to hopefully help slow down the breakdown of dopamine that we can add to it. It doesn't do anything to the disease, it doesn't do anything to dopamine, but it helps slow down the breakdown of it to make it last a little longer. And then there's the MOA inhibitors that can help with some of the side effects associated with it, as well as the Seroquels and stuff that will help treat some of the psychosis, which is, again, some of the side effects that you can have with it. Surgery-wise, phlebotomies, they're not, actually, this is coming in, they're actually doing, these are now getting more and more press because they're doing them, it's not that it's non-surgical, but it's minimally invasive surgery. I've been out of it 10 years now, so it's getting a little bit less for me. But they're doing a little bit more now. They do these more unilaterally, which because they're worried about speech issues, dysarthria issues. So if you predominantly have more problems on one side, a lot of these aren't too bad to use. But again, deep brain stimulators are used. We used them a lot in refractory, so patients that no longer can have the benefits of dopamine anymore, who've really run out of it, but are still functional and doing well. The use of deep brain stimulators, in then addition to continuing to use dopamine compounds, have done pretty well. It still works better, I think, more from a tremor standpoint and from a dyskinesia standpoint than it does from any kind of cognitive standpoint. So if you're looking at dementia, if you're looking at any of their cognitive issues, don't use deep brain stimulator for that. But if you're looking from a dyskinesia standpoint, then you're doing okay. Again, Parkinson's disease. There are centers here in city and in Tulsa. There's a big one in Tulsa. I think he's still there. That had a big Parkinson's group that was there that had a big movement disorder, a neurologist that moved in, and he was doing a lot. Anyway, I did it 4 minutes ago. And you're done. Questions, comments, concerns? Have fun in neuroanatomy.
Do they know what causes primary Parkinson's? Like, is it autoimmune or?
Not that I'm aware of.
What's the question?
Cause of Parkinson's?
No.
Stretch, go, because you'll need it.